of doing an injection, first of all, obviously, always start with proper aseptic cleaning of the area, and generally that's done by going from inside out. Imagine here we are going to do a myelogram, so we are going to inside out, and the idea is never cross over sterile that area that you clean, meaning that once I'm here, I can, even if I need to, I can change my hand and not cross the sterile area. In here, when I was a young man, we used to do 3 passes, meaning 3 different cleaning. But if you see here, I go here, mostly in the area that I already did, and I expand it out. So each area get 3 passes with the same thing, because look at that, I'm mostly in the area that I already did, and each area get 3 passes with the same thing. Then, obviously, to set it up. Now, there are 2 ways to do that. Somebody else set it up for the person who's going to do that, then they have to be labeled, meaning that somebody have to write down on each individual kind of syringe what they are. But if the person who's doing that actually filling it up, there is no need for labeling. Okay, so but still it needs to be, and this is what it is for, that if somebody else does it, that is how you label it. Now obviously I'm going to, you see that's the first thing I do. Then I give it time, and generally somewhere between a few minutes is enough for that. Now the idea of filling the medication you need, obviously you need to know what you need for the procedure. And before start, Ruby, what do I ask you? We are doing
the procedure. So today we're doing thoracic and lumbar myelogram.
Thoracic and lumbar myelogram. So this is a timeout, and that is almost like a routine for us. Just before I take my medication, we ask, what are we doing? She says that, and I repeat that. That's called closed loop. That's already our practically timeout, which is required, by the way. Then what I do, I know that I know we are going to do a thoracic and lumbar myelogram. I know what I need. I set up my syringes. So I know for this procedure, I'm going to need some local anesthetic to put the skin in the skin. So I take my medication. 3 cc is enough. I give it a little time, put a little air, shake it so the air bubble goes out, then get rid of the air. No syringe that has any contact with the patient should have air in it, except you are doing what we call the air kind of lock technique, but medication, they should have no. And since this is the local, I already put it on a hypodermic needle, and no question what it is. Never question what it is. Okay, so then for this procedure, I'm taking 10 cc of my thing, and the way she's holding it up for me, pay attention to that. It's the way that I can read that. These are little things, but just reduce the error, and that's extremely important. So I put a little air in it, so I don't have to work against this thing. I put a little air in it, and then draw out. And one of the things is these are multi-use kind of containers, and we never put anything back in this container from the syringe, meaning that if I take too much or something, you just draw it, put it in your field rather than back in the thing. Obviously, this is a clean thing you could put back, but by having a routine that you never put something back, is that if you use the syringe for something else, you are not contaminating the container. Again, I get rid of the air, and now if I was going to do like a epidural steroid injection as well, could you come back? If I was going to do like a epidural steroid injection, I would take like 2 cc, generally 1 to 2 cc of local anesthetic, and bring out the Kenalog. That is another reason, among other things, that I like Kenalog, because Kenalog, look at that, is milky. Meaning that once I put the local anesthetic with thing, the color of the content is already my marking. So I would have in that case three things. Hypodermic needle that tells me this is my local, my contrast, and that is now important part of this. Even before I put it in, and that's extremely important. What do we do, Robbie? Just before I put that in, before I put that in the patient, I get an X-ray.
X-rays.
And I put it just on the skin, and here it is, like the X-ray. Again. And I know now that is contrast. There's no question about that. With all the care you will do once a while, hopefully extremely rare, you put it on and you don't see any X-ray sign, opacity, and you know whatever it is, it's not contrast, okay? And another thing that is in a routine is that for the same procedure, always use the same syringe. That's another kind of backup. Like in my milligrams, my 10 cc syringe is always going to be my contrast. My 5 cc is going to be always my local anesthetic. And in other procedures, other syringe are going to be, but so I have the marking initially with the hypodermic needle. I have the size of the syringe. You just have to develop that it's always the same, and that reduces the chance of having wrong kind of medication in the wrong place. God forbid, you put that local anesthetic intradurally. The protocol for that is turn the patient, let the patient sit up. The legs are going to go numb, but this is it's heavier material than the CSF, so it will sink down. Practically, you gave them literally a spinal anesthesia. That's what they do when a pregnant woman are giving birth. That's what they do, but it's a very controlled way and so on. So the problem here with the bupivacaine is that its half-life of it is somewhere between 4 and 6 hours. So you have to make sure that they're upright, that they're not head down, absolutely not, head up, and they're sitting, so all the gravity takes that, and then they're going to not feel their legs for a while. It still is a ER transfer. Mm-hmm. And the reason it's a ER transfer is because if that material comes up, they're going to have a sensory level that's going up. If it, God forbid, reaches the cervical spine, then you have to start bagging them. Mm-hmm. Okay, so we have a bag, cart, and so on. Do we have all of that here? We need to have that. Yeah. Okay, that is part.
That is Janelle. She's doing.
Okay. Yeah. Okay. Very good. Okay. Well, that's it actually. Thank you.
Okay.